participate in the mini debate regarding the alignments in the totally plastic. And I will be the mechanical alignment pro. So my presentation's title will be like upholding the gold standard alignment against the promises of kinematic alignment. So for me, as an orthopedic surgeon, and I'm doing roughly around like 80 TKA cases per year, including everything primary, revision, hinge knee, of course. The ultimate goal of the total knee replacement is not to recreate a natural knee that's already failed, but because we're replace the knee so that we create an artificial knee that we hope that not going to fail and reliably eliminate pain and restore the function. So why we're here debating, right? So let's just look back a little bit what the literature said. So in a meta-analysis, I'm not gonna cite any single papers, but a meta-analysis of 2026. And it says that KA achieved midterms clinical outcomes generally comparable to MA in primary TKAs. The high quality random trials found no clinical meaningful advantage of KA than the MA. Let's see just the clinical trials that has the follow-up times of more than 2 years. Let's not just look at the 2 years, okay? For example, like here we say a research of Sion in 2017 with the follow-up times of 8 years, and the author concluded that overall clinical is equivalent between the KA and the MA. For another really good clinical trials of Young and Young in 2020 with the follow-up times of 5 years, the author explicitly cautioned against the routine of kinematic alignment. Another research from Dosset with the follow-up time of 13 years says that the survivorship conclusion was underpowered due to low event rates. Another 10 years follow-up times research coming from Gibbons saying that the author stated that MA remains the reference standard. And a lot of other papers. And all the papers saying that there are no clinical advantage of kinematic alignments against the traditional mechanical alignments. If it is not enough, then I will cite a guideline from the AOS, the American Academy of Orthopedic Surgeons, one of the most reliable guidelines for us. And this is the most updated that I've just downloaded 2 days ago. And they say that there are no difference in composite or functional outcomes or complications between the kinematic and the mechanical alignments principles in the total knee arthroplastics. The qualitative evidence is high and the strength of recommendation is strong. 4 stars, it is the strongest recommendations. So we say that no evidence of better clinical outcomes, better function, less pain, or natural feelings. All these things promising by kinematic alignments, just the hype. No rigid clinical evidence of that. So it is just a hype designed to appeal to our emotions rather than scientific rigor. And one other thing we want to say, we should know what we put in our patients. With the mechanical alignments, we optimize mechanics, we're trying to protect kinematics in the long run. For kinematic, prioritize the kinematics and accept the risk in mechanics. Why do I say that? Because we put artificial materials in the body. So we must obey the laws of physics and we must respect the biomechanical environment in which the implants were validated, also known as the mechanical alignments, because most of the implants nowadays available in the market is validated under the mechanical alignments conditions. Also, we have the artificial materials. We know that it is a dead metal poly materials. We have no Wolff law, also known as no remodeling according to a stress. That means we cannot force the material to bear loads as the way the living cartilage does. Also, as the test of time. The mechanical alignments has the world's largest national registry, so coming from the National Registry of the UK, the Australian Orthopedic Association National Joint Replacement Registry, the American Joint Replacement Registry, or the Swedish Arthroplasty Registry. All statements that the survivorship risk after 15 to 20 years consistently around like 90 to 95%. While with the kinematic alignments, we have data, of course, absolutely, but the data is coming from, some authors, and look at the names of the author here. He is the father of the kinematic alignments, one of the founders, one of the experts, one of the most sophisticated and talented knee surgeons regarding the kinematic alignments. So, as I said, a successful TKA is not measured in year 1, year 2, but it should be measured in the year 15 to 20, in thousands or millions of patients. So, if I tell you is to replace 30 years of a proven success method with 10 years of data, personally, I do not want to gamble, especially for the young surgeons or, with conditions like Vietnam. The next thing I would like to say about is the reproducibility. With the mechanical alignment, we have a really steady target. We have a neutral axis of 0 degrees. Even you do it in a conventional instrument way, you do it in navigation or robotics, everything, we just set it 0 degrees. Straightforward teaching, easier to teach, easier to train, easier to quality control, and easier multi-center sanitization. For the kinematic alignments, you have a lot of options. You have dynamic target, you have different blueprints. Of course, you can say that, okay, I am customizations for the patients, right? But now, okay, that is for the experts. That is not for everyone. You have an unrestricted KA when you say that it is, okay, it's too much. I cannot reproduce a 9 degree, 8 degrees of varus knee naturally, okay? I'm going to restricted KA. When you have robot, you have functional KA, you have inverse KAs. That's a lot of things to consider, right? So, in order to have a concept of philosophy to work, we should let it work not only in the hand of the experts, but also works across the entire orthopedics community. That is mechanical alignment. And one more thing that I will mention about, because I was in part inspired by the hinge knee talks. Look at these knees. Will you try to restore the pre-arthritic anatomy of the knees? No, I personally no. I would, consider the hinge options. And the hinge option is pure feat of mechanical engineering. Strict, neutral, mechanical axis of 0 degrees for the knee, for the hinge knee to work. There are no such things as I understand, is a kinematic alignment hinge knee. I don't know, not search on the internet, I don't see anything. So in conclusion, I am not against new trends. I am not against new technology or the evolutions of surgical techniques. But before we be the innovators, let us be the protectors first. Let the experts trying to do new things and validate the new things. The natural fields of KA is just a promise. The mechanical increased stress is the realities that we put in the patients. Don't force the dead metal to play the role of a living cartilage. Mechanical alignment is not an old way. It is a proven way for the last 30 years. In the game of long-term patients care, I think proven matters more than the trending. So that is my debate part. Thank you very much for your attention. And mechanical alignment for me is still the best and gold reference. Thank you.
Thank you, Dr. Bao, with the very impressive presentation. And now, what we see about the KA from Dr. Tan.
Thank you, Dr. Bao, because he gave us very strong suggestion, strong evidence. Because the American Orthopedic Society have a strong level 1 evidence between MA and KA. They show MA and KA equal function. But the problem is when they do the KA in some developed country, they use some platform, navigation, robotic, or even patient-specific instrument or some kind of computer assisted. So the problem for us is to how we adopt KA in our circumstances to answer the question, MA or KA, which is the better? We must stand in the position of the referee rather than we stand in the position of the soccer player. So that's the reason we take this research in our circumstances. We do KA with the conventional instrument, with the naked eye, and some manual instrument. And this is the prospective KA. We compare with the history, MA, around 60 in each group. And to reduce the bias, to reduce the confounder, we use the statistic with the help of some statistic. We use propensity score to reduce some bias between A, Z, or some kind like this. This is our procedures. We still use manual instrument with some modification with some 3D variable cut, and we still use intramedullary guide, and especially posterior reference femur cut is necessary for protecting liquid acids. So our measure, we have three components. First, clinical, we compare range of motion, some need society score, which in the range of objective need, and the patient report outcome. We have orthogonal warm-up, forgotten short score, and radiographic propensity score. So we adjust A and some to reduce some bias. And the another reason we want to verify is we want to find out which subgroup of patient may benefit KA than MA. We compare the subgroup according to the severity of the virus and the CPAP phenotype, hormonal blend alignment phenotype. So this is our some statistic to reduce bias with propensity score, and we found that with the KA we had a superior objective need society score, which means more than 14 points rather than MA. But for the patient report outcome, there's some study say that KA is better, KA is not inferior, and this is our result. The confidence interval say no, there's no difference between KA and MA. Although we may sound KA is better, but statistic is statistic. They don't lie. The data show the equal patient report of outcome. However, if we look into the limb alignment control, we have seen that when we do MA with your naked eye, there's some issue. The outlier more than 6 degrees, maybe more than 30%. But if we do KA, the limb alignment may control better with the outlier below 6 degrees, 6%. Because this comes from the cornerstone of the valgus femur cut and the tibial bladder cut. If we cut in the manual case with the MA, we cut the fixed femur valgus, and if we fix the fixed tibial valgus. And usually, if your patient suffers from severe deformity, ligament release may be not optimal, not enough. So most of surgeons cut more tibial varus to optimize constitutional varus. But like some research paper, if you intend to cut tibial varus 3 degrees, maybe you have the error maybe for 5 degrees, and this causes the poor total limb alignment control. But in the KA, we cut the femur individualized, so maybe we cut 9 degree or 10 degree varicose, and it compensates for the tibial varicose, and we have the total limb alignment still confined in 6 degree with the shape range of motion. Another problem is that take a look to our knee phenotype. Although many countries have published knee phenotype, Korea, Asia, and other countries, they also publish their own data about coronal blend alignment knee phenotype. But still, after more than 10 years, we don't have any data. And in this recent data, we checked the CPAC phenotype of our population. We found that in Vietnamese, the overall CPAC is type 1 and type 4. It means that various constitutional technicality of population and the joint line apex distal or joint line apex horizontal still take the major, and these patients may benefit KA than MA in controlling alignment, and this also illustrated in some McDessie research, the author of the CPAC. How about the subgroup effect? We don't see any subgroup effect. Either more virus or mild virus or CPAC phenotype virus, there's no subgroup benefit KA than MA. So our conclusion is, in our circumstances, KA with manual instrument, KA still KA and MA have the same patient report outcome. It is a big obstacle, not in our circumstances, but on over the world. Patient report outcome is an optimal obstacle. We must surpass the 87% patient dissatisfaction. However, with the manual KA, we can control limb alignment better than manual MA, and our data show there's no subgroup benefit KA. So I'm saying that at the beginning of my talk, like a football player, like football game, I play the stand and the position of the referee rather than play a soccer player. So in some case, I do KA, but then still some case I will do MA. You ride motorbike and you can ride car. Is it better that you can only ride motorbike? So that's the reason. So it should be taken into consideration in your neuropractical in totality prognostic. Thanks for your attention.
Thank you. This is my presentation, and you have to prepare your question for the other, okay? So I can say for the brief way that MA is for the neutral medical assist with the reversible ligament, right? And they have a long-term evidence for and the KA just restore the native joint line, and then it's maybe improve a little bit early the function of the patient, just a little bit in, or my opinion, just in 2 or 3 weeks early, right? But we need to choose the patient, and now you have to ask for the order about, you have to protect your opinion, okay? And then we can ask from the audience. You can do it first, Dr. Bao.
Yeah, okay. Thank you very much. Because I am a MA surgeon, and I also really fascinated about the KA concepts. It's really interesting when you're trying to restore the knee, which is the natural knee. But the problems that I consider the most would be you do a new concept based on the instruments, based on the implants that was originally designed for the MA concepts. And besides, for me, the MA was like, okay, I can totally calculate it and I can totally seize it, I can totally, align it by my own eyes, rather than trying to restore the things that I need to imagine that, okay, 15 years ago, 20 years ago, the knee should look like that kind of thing. So, I don't know, because I just have a feeling of like, I rather believe in something that I can measure, that I can see with my own eyes, rather than just imagine. Of course, with the new techniques, with the new implants, the KA is becoming trendy. I'm not against it, but I just wait to see how it goes in the future. That's my opinion.
This is the understandable answer because in the beginning of our last week, when I do KA, I do with navigation. But when we do navigation, I find shape, alignment, and shape. But I highlight this and move through some manual instrument. So until now in my practice, I still prefer KA because although KA and MA have the same function, there's some report say that KA is better, but that is so advertised because the long term, maybe even short term, when our patient come to us after operation, check the patient dimension, and I find that there's nothing that for function after operation, even 6 months or 1 year or 2 years. But the problem comes from our technique is that when you do MA, when I do KA and I look back what the case I do in MA and I find out MA is rather difficult, more difficult than do KA. Because ligament balancing so sophisticated and complex. Some in MA case, we usually accept some laxity in the lateral side with the various deformity. But in the KA, when we do KA with the balanced knee, you will feel satisfied, ligament balancing, sometimes like that, and not, even though it's not transferred to patient before outcome. But I think that is the better way to keep innovation, keep developing in the future. And even KA still develop in the future with the some you see until now they do functional alignment. Functional alignment comes from the base of KA with the robotic platform. So if I have, however, in some case, I will only choose MA, especially some case I will recurvator, so laxity, unpredictable ligament, so laxity. So you can do KA to compensate the laxity, and that in some case we must move to the in-kidney or CCK like this. So the problem is right patient, right method, and you have an optimal function.
Totally agree. I add one more thing is that in my opinion, it's like MA and KA is not like completely different, but we can find something in the middle. For example, restricted KA, which is you're trying to restore the prearthritic knee, but the in the range of deformities, like not more than 60, kind of in terms of alignment. So I think that the collapse, like the overlaps between the two concepts, which is where we're gonna maybe there common sense of analysis, right? Okay.
May I have a comment? It's not really a question, but first, I'm a KA guy,
Yeah, sure.
so I kind of oppose your opinions. So, to do a total knee, there's some goal you have to achieve. First, stable knee, good mobility, and then good alignment. if you do KA, naturally you're gonna have good mobility and stability. Because you preserve it. Sometimes you have an alignment that's maybe unacceptable of the X-ray or an MA gap. That's why they switch to fractional alignment. But the truth is, not all the KAs surgery, I mean, not all the KA TKs gonna go with a terrible alignment. We have to differentiate between a varus knee, for example, because of the arthritis, and a varus knee because patient have some comorbidity before, like Lyme disease or something like this. They have severe varus, not because of the arthritis. If the varus from the arthritis, you do KAs after surgery, you have beautiful alignment. So that's very common. And the second thing is, you mentioned, Dr. Ting, you mentioned that sometimes you do MA, sometimes you do KAs. So my question is, why you already switched to KA? Can you still stay with MA sometimes?
In our case, 80% of case I do KA and 20% still do MA. I do KA because what I mentioned, after ligament balancing, after fueling, and stable knee. However, I still do MA in some kind of hydrorecurvator and some kind of severe one because although there's some research found that some valvular knee, there's no change in ligament, lateral ligament, but for our my cases there's some deformity, and that deformity compensated by bone cut along human balance between the bone cut and ligament balance. For the first time when we study obesity, there's some famous proposed. They say that rhinoplasty is an operation of ligament. But when I found back the original article, I found that the original book comes from Professor Isaac. He said rhinoplasty is an operation of horn and ligament, not just ligament. So I still use MA in some complex case.
Yeah, I mean, the right question is, why don't you do restricted KA if you already do KAs?
Because we don't have a platform that we send on computer. If you want to do restricted KA, you must have a platform on computer like that. So at the moment, we still use unrestricted KA with a manual instrument.
Because I heard that you have navigation in your hospital.
Maybe said in the past, just 5 years
Right
ago. And at the moment, we're looking for some robotic stuff.
Okay, thank you. Now we can move to the comment from the moderator.
Just a question for Dr. Bao. So at the moment you're pure MA. What would be the short or medium term results, or what are you looking for to convert yourself into a KA person?
It's hard to convince even myself to convert from an MA to a KA because you mean like what will make me convert, right? I was trying to convert myself, even doctors from my department staff trying to convince me to try the KA, but I find it's hard because for me the things that was created for the MA, which is the implants that we're using, it was created for the MA. I'm using the MA. The instrument was for the MA. I'm using the MA. There's no sense of using the tools next to one thing to do another thing. You can do it, you can test it, you can try to do it in the lab or whatever, but I don't think it's going to be safe to do it on patients. That's great, the first thing. For the MA, which was, for the KA, which was told that would have less pain because of less ligaments release and good range of motions at the very first few weeks. For me, the results of a arthroplasty is not in terms of a few weeks, even not in terms of a few years. It should be a long term. It should be a survivorship of the implants and also the pain relief of the patients. So for me, I am thinking that the results that I'm achieving right now is not perfect, but acceptable. And I'm trying to do what I'm doing better rather than trying to do a new thing that I'm not really believing or really have experience or training.
Once again, thank you for both for your contributions. Round of applause for our debaters. Thank you.
Thank you very much.